Thank you, Dr. Iqbal sir, for that kind introduction. At the outset, I would like to thank Georgican sir for giving me this opportunity and the CIPLA team for sponsoring this session. So today we'll be discussing about renal artery stenosis. So renal artery stenosis, we are more focusing about the native kidney renal artery stenosis rather than the transplant kidney renal artery stenosis. So we'll try to find out what are the usual causes of RAS, how to diagnose renal artery stenosis, and how to treat them. And as Iqbal sir said, whether to go for medical treatment versus interventional way of management. So renal artery stenosis, what it means is that there is narrowing of one or more renal arteries, a condition that can lead to hypertension, which is we label as renal vascular hypertension, and ischemic nephropathy. And eventually, when the renal vascular hypertension and the renal artery stenosis persists for long, it will result in kidney damage, which will result in ischemic nephropathy. So, coming to the causes of renal artery stenosis, atherosclerosis accounts for almost 80 to 90% of cases of renal artery stenosis in adults, and which is produced by lipid-laden plaque into the lumen of the renal artery. And around 10% of the cases are because of the fibromuscular dysplasia, and it is because of the structural abnormalities in the wall of the renal artery, which will result in stenosis at multiple segments or throughout the renal artery. So coming to the few more details regarding the causes. The atherosclerosis, we know it affects usually elderly people. At least the patients are usually more than 50 years, more common in men than compared to women. And the usual risk factors for atherosclerosis like diabetes, hypertension, dyslipidemia, smoking, all those causes will result in atherosclerotic renal artery stenosis. When coming to fibromuscular dysplasia, it is more of a younger age group, predominantly women, and it's not the plaque which is producing it. Is not non-atherosclerotic, and it's the structural abnormality of the arterial wall which produces stenosis of the renal artery. Now, coming to the location, when you talk about atherosclerosis, the location is predominantly at the ostium or the proximal 1/3 or the first 2 centimeters of the main renal artery. And the angiographic appearance is of irregular narrowing and calcified plaque that you can see on an angiogram. Whereas in fibromuscular dysplasia, it is more of middle and distal part of the renal artery which is involved. And it classically, what we say is a string of beads appearance because of the alternating stenosis and aneurysmal dilatation, which produces classical string of beads appearance in angiogram. And this is most commonly seen in the medial fibroplasia kind of fibromuscular dysplasia. Now, apart from the atherosclerosis and the fibromuscular dysplasia, which accounts for majority or the major chunk of the causes, there are rare causes like vasculitis, Takayasu, giant cell arteritis, polyarteritis nodosa. Then you can have mechanical process like arterial dissection or extrinsic compression from tumors or retroperitoneal fibrosis, or it can be a thrombus or embolic phenomenon which produces a reduced perfusion to the kidneys, or it can be due to APLA, post-radiation, congenital abnormalities like aortic coarctation. All these can produce renal artery stenosis, but our focus will be more on the atherosclerotic cause of renal artery stenosis. So whatever be the cause, when there is a stenosis in the renal artery, the perfusion pressure in the kidneys goes down. That is when it is less than 70 or 85 millimeters of mercury, the juxtaglomerular apparatus senses it that the perfusion pressure is on the lower side, and it releases renin. So renin, what it does is that it converts the angiotensinogen to angiotensin 1, and then the angiotensin converting enzyme or the ACE enzyme converts the angiotensin 1 to angiotensin 2. And this angiotensin 2 acts on your AT receptors, resulting in systemic vasoconstriction, which will result in your hypertension, which is very classical of renal artery stenosis. Apart from the angiotensin causing hypertension, it also acts to release the aldosterone, which will result in your salt and water retention, sodium and water retention, and which is the reason for volume overload in renal artery stenosis. This is the primary mechanism that is happening, the hormonal changes that is happening in renal artery stenosis. But if this RAS activity and chronic ischemia goes on for long, it will result in microvascular dysfunction, and ultimately the patient will end up having a chronic damage, permanent damage, known as the ischemic nephropathy. Now, as Georgian was saying, the gallbladder experiment, that proved to us that if you clamp the kidney, the classical one was the two kidney, one clip model and the one kidney, one clip model. When you clamp the renal artery, he found that the BP goes up. And when you release the clamp, the BP improves. So that was the reason why it was known as the gallbladder experiment. And that is the way by which we came to know about renin and how it causes the hypertension. And when you have a unilateral renal artery stenosis, classical is the two kidney, one clip model, then the stenotic kidney produces the renin and angiotensin, which will result in vasoconstriction and hypertension. But the good thing is that the non-stenotic kidney is normal. So it can result in a pressure natriuresis, and the salt and water is excreted. So the BP doesn't go too high and it does not end up having a volume overload kind of a situation. But when it comes to bilateral renal artery stenosis or a single kidney with renal artery stenosis, the pressure natriuresis cannot happen because there is no normal kidney to produce that pressure natriuresis. So the BP elevation will be more severe and the patient can have volume overload resulting in recurrent pulmonary edema. So that is the pathophysiology and how the effects of the renal artery stenosis produces in the clinical setting. Now, if you look at this arrow, you can see that when you trace the arrow, like here, initially there is a reduced blood flow because of the renal artery stenosis. Then the renin release happens, which will lead on to angiotensin vasoconstriction and the sodium retention. And eventually, if it goes like that, the tissue hypoxia starts happening. The medullary hypoxia starts happening, which will lead on to oxidative stress injury, mitochondrial dysfunction, microvascular injury, which will eventually lead to tissue fibrosis and atrophy, resulting in ischemic nephropathy. So that's a course of a renal artery stenosis from a mild renal artery stenosis to progressing to ischemic nephropathy. And if you see here, you can see that this is the area where the renal vascular intervention may be beneficial. So when the renin release happens and sodium water retention and the BP is high, then the intervention may be useful at this point. But as the tissue hypoxia progresses and it goes into a kind of a permanent damage to the kidneys, thereafter the revascularization will not be of any benefit. So this you have to keep in mind. Now, coming to the what are the usual incidents, or how common is the atherosclerotic renal vascular disease or renal artery stenosis? And if you, have been studies and which showed that in heart failure, the incidence of renal artery stenosis can be as high as 54%. And whereas if it is a patient with heart failure and CKD, it can be as high as 68%. When it comes to peripheral arterial disease, the renal artery stenosis prevalence can be 22 to 45%. And when it is a coronary artery disease, the patients can have 14 to 30% of patients can have renal artery stenosis. And in patients with hypertension, it can be as high as 14.1%. It doesn't mean that all the patients are symptomatic, but if you look for it, the patients can have renal artery stenosis. When you have hypertension and diabetes, the incidence goes up to 20%. And in advanced CKD, above the age of 50 years, the prevalence can be 5 to 22%. And in dialysis patient, it has been seen that almost 11 to 22% of the patients can have renal artery stenosis. So this is a very common thing in your common clinical practice, that if you search for it, you may find renal artery stenosis. But eventually, you don't have to search for renal artery stenosis in almost all these clinical settings. So then you should have some red flags that makes you search for renal artery stenosis. What are those? So first one is the recurrent flash pulmonary edema, or also known as the Pickering syndrome, which I will talk a little bit later. And then the resistant hypertension, that is the BP is not getting controlled with 3 or more drugs, including one of which is a diuretic. Resistant hypertension. Renal asymmetry. If you have an ultrasound which shows that there is an renal asymmetry more than 1.5 centimeters between the two kidneys, then you have to start thinking about a renal artery stenosis, especially if the patient is having an uncontrolled BP and this patient has extensive atherosclerosis. You should think about it. Then you start a patient on ACE inhibitor and the creatinine rises to more than 30% with a high BP, then you have to think about a renal artery stenosis. Then the age of onset, that severe hypertension less than 30 years, you have to think about fibromuscular dysplasia. And if the hypertension is of a sudden onset more than 55 years of age, then also you have to think about renal artery stenosis in the evaluation. And when you have a physical examination which shows that you have abdominal bruit or renal bruit, then also the chance of you having a renal artery stenosis definitely goes up. And then you have to search for a renal artery stenosis with diagnostic modalities. Now, a few words about Pickering syndrome, or also known as the cardiac destabilization syndrome. Previously, we used to call it the flash pulmonary edema of renal artery stenosis, which usually happens with bilateral renal artery stenosis or a unilateral renal artery stenosis in a single kidney. So, only in those situations the kidney is not able to excrete, or the pressure natriuresis does not happen, and there is salt and water retention, which will result in volume overload and pulmonary edema. And this was first described by Thomas Pickering in 1988, and hence it is called the Pickering syndrome or the cardiac destabilization syndrome. The management is usually diuretics and the oxygen for your patients, but most of the times what we usually see is that when you start the diuretics and aggressively manage the blood pressure, the creatinine gradually worsens, and the hyperkalemia also sets in most of these patients. So that also you have to keep in mind. Now, coming to the diagnosis part, so at this point, we will have our first poll. So, Varsha, can we have the first poll?
Yeah, Muzaffar, can you please play the poll? Headcast. Yeah, it's there.
So in the context of Doppler ultrasonography, which of the following hemodynamic parameters is generally accepted as a criterion for significant renal artery stenosis? Can we close the poll? Over to you, Dr. Iqbal.
Can I see the results? Can I see the results, please? Yeah, peak systolic flow velocity more than 180 to 200 is the majority of the candidates had ticked it. Like, can I have Dr. Kishore there? Kishore there? Yeah, Kishore, can you highlight about these results, and can you say which one of the following in the right context can you believe give the most value in diagnosis?
As rightly the majority has opined, peak systolic velocity is the most sensitive. But then the problem of Doppler is it is highly operator dependent and highly dependent on the body habitus and the cooperation by the patient. So, but then peak systolic velocity is the most sensitive. It measures a peak blood flow, and something about more than 180 to 200 is definitely a good sensitive indicator towards major renal stenosis. And higher the PSV, the higher the degree of stenosis also. Comparing the other things, the acceleration time is again difficult to. The only thing that is severe stenosis, there will be a power set charges over there when you look for the acceleration time. The ratio, the renal aortic ratio, is the ratio with the PSV to the aortic PSV, renal PSV to aortic PSV. Again, more than 3.5 is a strong indicator of stenosis. Less than the normal values, less than 3 to 3.5. When the more than 3.5 is a strong indicator of hemodynamically significant renal artery stenosis. RI is it is highly again operator dependent, and anything above 0.8 indicates there is some amount of renal damage has happened. There is intrarenal, so there's a negative predictor for it has a significant negative predictive value for recovery after correction of stenosis. So here it is PSV is the most sensitive, but then it is high, again operator dependent, and you need a good visibility of the artery to get a correct value.
Thank you, Dr. Kishore, for your comments. Over to Dr. Geo Philip to continue the talk.
Yeah. So as Kishore sir said, peak systolic velocity is something more than 180 centimeters. Definitely it has a high sensitivity in the sense that as the stenosis increases, the peak systolic velocity also goes up. And the renal to aortic ratio more than 3.5 also signifies that the stenosis is significant. And the post-stenotic area, you get turbulent flows and the classical pulsus pauses, etardus kind of a waveform. And then you have other things like the RA difference between the two kidneys more than 5%, and the acceleration index less than 3 meters per second squared. All those things can be other markers which helps us in identifying and quantifying the renal artery stenosis by a Doppler method. So apart from the Doppler, what we once you have a screening with the Doppler, definitely if you want to confirm and to quantify the stenosis, you usually go for a CT angiogram, and it accurately reveals the anatomical details of the renal arteries and its branches. And this is usually compared to DSA. The sensitivity is around 59 to 96%, and the specificity is around 82 to 99%. It varies. And the other way you can find is magnetic resonance angiogram, or the MRA. Here also the sensitivity is around 92 to 97%, but the specificity is around 73 to 93%. The major limitation of MRA when compared to CT angiogram is that the CT angiogram and the MRA can pick up proximal lesions, but the distal lesions, when it comes to MRA, it's not as good for picking up distal lesions as well as the intraparenchymal renal artery segment. So for distal lesions, always CTA or the CT angiogram is better than magnetic resonance angiogram. And apart from that, the CT angiogram, you have the risk of the iodine contrast causing AKI, and magnetic resonance angiogram, though we don't see there is at least a theoretical risk of nephrogenic systemic fibrosis with using gadolinium contrast in magnetic resonance angiogram. And then you have a non-contrast modality, that is a blood oxygen level dependent MR imaging, or the bold MR imaging, where you can identify the tissue which is hypooxygenated, where the oxygen is on the lower side. If you look at the picture on the lower side, on the bottom, you can see as the fibrosis, and once the reduced blood flow goes on to produce oxidative stress injury and then goes into fibrosis and irreversible kidney injury, you can see that in bold MRI, the red ones are the deoxygenated blood. So the deoxygenated blood increases, and whereas in the initial stages, the deoxygenated blood content is on the lower side, and on the later stages, the deoxygenated blood or the oxygenation is impaired, especially in the medulla in the bold MRI imaging. So it is helpful in identifying the oxygenation of the kidney tissue. Now, the gold standard definitely is digital DSA, or the digital subtraction angiography. We usually go for it when you have a high suspicion and you are already planning for a intervention. You go for a DSA, and in the same sitting itself, if possible, we go for the endovascular intervention. That's a usual thing, because we don't want to expose the patient to a high degree of contrast, and also we are producing it is an invasive procedure, so we don't want to put the patient for an invasive procedure just for the diagnosis sake. Mostly it's planned along with the endovascular intervention procedure. And in severe atherosclerotic renal artery stenosis, we usually have a stenosis more than 70%. In those cases, you don't need further testing. Most of the times you can proceed with intervention. If you have other definite indication for intervention, you can proceed. But in moderately severe stenosis, that is 50 to 70% stenosis, definitely you have to confirm the hemodynamic severity with other values. So how can you identify that hemodynamic significance of the stenosis? And then you have to think about something called as the translational gradient, where there is a distal sensor and the proximal sensor when you do the procedure. And if the gradient is more than 20 millimeters of mercury, it shows that the hemodynamic significance is there. And if the PD by PA ratio, PD is the pressures in the distal renal artery, and PA is the pressure in the aorta. If it is less than 0.9, that also confirms ischemia. Whatever be said, you have to make sure that the kidney is, when you are planning for a procedure, you have to make sure that the kidney is viable. And for that, your resistive index, renal resistive index of RI, something more than 0.8 shows that your kidney parenchyma is damaged. It's unlikely that the renal function is going to improve with your revascularization. So that also comes into play when you are thinking about hemodynamic significance. Now we'll go on to poll number 2. Can we have the poll number 2? So a 72-year-old patient with long-standing hypertension and stable chronic kidney disease, stage 3, is found to have a ostial stenosis of right renal artery during an evaluation of Brui. Blood pressure is currently on a regimen of a thiazide diuretic, AC inhibitor, and calcium channel blocker. Based on the findings of CORAL and ASTRAL trials, what is the most appropriate next step in management? Can we close the poll? Over to you, Dr. Iqbal.
Yes. Poll results, please. Yeah, majority have opined about the continued optimal medical management, including statins, antiplatelets, and BP control for this scenario. Dr. Gilesh, are you there?
Yeah, good evening, sir. My
Good
voice is
evening.
audible?
Good evening. Yeah, you are audible very much. Can you highlight about your experience and how you go about in such a scenario, and what are the exceptions to this rule? Thank you.
Sir, as you see in this patient, what the history has been given is 72 years. It's an elderly male patient. And they have mentioned that it's an osteal stenosis. So most likely it is probably because of atherosclerotic stenosis. They have also mentioned the point that the patient's blood pressure control is stable. It's stable CKD3A with good BP control and optimal therapy. With they have included ACE inhibitors, calcium channel blockers, and antiplatelets. They have not given any history regarding any emergent situation like a flash pulmonary edema or any progressive renal failure, because they have mentioned it is as stable. There is no history of any refractory hypertension also, because BP is controlled. They have never said any extra symptoms there. So with that context, if you look at the other part of the question, they have mentioned about the two trials also, that it is in accordance to Astral and Coral trial. So when you mention about Astral trial, now it is about done across around 2009 with about 806 patients, mainly including the atherosclerotic renal artery stenosis, where they compared revascularization versus optimal medical therapy. And they found that there was no difference in the renal function progression or BP control or CV events, including mortality among the two groups. And following in 2014, we had the Coral trial, where they mentioned about 2,947 patients with significant RAS. The difference between the two trials was in the Astral trial, the limitation of the study was that the obstruction, the renal artery stenosis percentage was approximately only 50% or even less. Compared to us, in patients with Coral trial, they really took some significant RAS, I mean, around 80% and approximately 60-70% stenosis. And there also, they didn't find any difference, because it looked also at the cardiovascular events, but they did not find any difference in the heart failure rates or the renal progression or any advantage in major blood pressure control or avoiding complications. So that indicated that optimal therapy was fine. There are other studies also at that point, like Drastic and STAR, which also mentioned that. The other options, when you look at it, surgical revascularization, which they mentioned in option number 3, that in that case, surgical revascularization only comes into play when there is a complex anatomy, or basically there is a failed endovascular stenting procedure, or a concomitant any aortic surgery. Those are the places where you consider, or a kinking, which cannot be negotiated, where you can think about surgical revascularization. But mainly, the last option which they had mentioned about ACE inhibitors, but ACE inhibitors is not contraindicated in a unilateral RAS. Basically, it can be given and should be considered, and only in bilateral RAS if there's more than 30% that where it's contraindicated. So I think all the crowd which is mentioned as optimal medical therapy stands out, and in these cases, these are the patients where we should consider that with an intervention only in those patients which I mentioned as major flash pulmonary edema, patients with refractory hypertension, or a rapidly progressive or any progression renal failure. So I think that would be that would answer this question, sir.
Thank you, Dr. Gilesh, for those fantastic comments. Over to Dr. Geo.
Yeah. So continuing on what Dr. Vilesh was saying, I'll just elaborate on a few things. So 90% of the cases of hypertension due to renal artery stenosis is usually controlled by your pharmacological treatment alone. And optimal medical management, when you say about it, it's your blood pressure management, which is the main thing. The usual agents that we use is ACE inhibitors or ARBs, then your calcium blockers and your beta blockers, and sometimes your diuretics overload, as well as your hyperkalemia. So ACE inhibitor and ARBs, you should be careful when you are starting in a patient with renal artery stenosis, especially if the patient has bilateral renal artery stenosis or a renal artery stenosis in a single kidney. You have to be very cautious, and any rise of more than 30% in the next 1 to 2 weeks, then you have to think about continuing ACE inhibitors, and you have to judiciously adjust the dose if needed. And apart from the hypertension control, your regular atherosclerotic management, which includes, just like your coronary artery, you have to think about aspirin, then high intensity lipid therapy as the lipid lowering therapy with statins, then lifestyle modifications including smoking cessation, weight control, salt restriction, your diabetes control. All these plays as an important. It's almost like a coronary equivalent. So you have to treat just like a coronary artery disease when you have a patient with a documented renal artery stenosis. as Dr. Vilesh was saying, in the 1990s, there were case series which showed that angioplasty was being done for renal artery stenosis. And then came the randomized controlled trial, first one that was in drastic trial in 2000, which included 106 patients. They compared angioplasty versus medical therapy. Angioplasty was pure balloon dilatation. It was not stenting. They didn't find any BP improvement or renal function improvement. And then came the 2006 STAR trial, which included 140 patients. There they did the stenting versus the medical therapy, and they also didn't find any significant benefit in the preservation of renal function. After those trials, then came the Astral trial in 2009, which included 806 patients. They also looked for the creatinine over a period of 5 years. They also didn't find any benefit of stenting versus the medical therapy. Then came the Coral trial in 2014, which included 947 patients. They also had few patients with more than around 80% stenosis, as Dr. Vilesh said. But the number of patients were having the number of patients having high refractory blood pressures were on the lower side. They had only moderate blood pressure, and more than 2 agents were mostly the mean blood pressure medication agents that they had. So all these studies had their limitations of its own. So if you say what were the limitations of Astral and Coral, they excluded high risk patients. So both the studies didn't include flash pulmonary edema patients. The recurrent flash pulmonary edema patients were excluded from the study. Then the patients did not have refractory hypertension. Most of the patients have relatively well controlled blood pressures in both studies. And the declining renal function was not included. Patients high risk with declining renal function were not included in this study. And the severe renal artery stenosis were underrepresented in both the studies. And some in one of this Astral study, there was a crossover between the medical the group as well as the interventional group, because the medical group, some of them were taken into the interventional group also. There was a crossover of patients as well between the arms. And both the studies use different diagnostic modalities. Some use duplex for diagnosing renal artery stenosis, where some others use CT angiogram. So there was not a uniformity in diagnostic modalities, and they lacked procedural consensus. It was a multi-center study. So there were centers which had 1 or 2 patients. So there was a procedural inconsistency between the centers also. So those were the limitations of the Astral and Coral, though they showed that the medical therapy was not inferior to, or the interventional therapy was not superior to medical therapy. And so the historical view of opening the vessel to cure the pressure was the historical view. Then based on the Coral and Astral, the evidence-based view, it changed from treat the cardiovascular risk, and the medical therapy is the first line rather than the going for intervention in all renal artery stenosis. So that was a shift at that time. And then around that period itself, we had the ASPIRE 2 study and the Hercules trial. In the ASPIRE 2 study, they stented when after failed angioplasty, the patients were monitored, and they found that the BP decrease was good and it was statistically significant. And the Hercules trial also, they did stenting in significant renal artery stenosis along with uncontrolled hypertension. So the patient group was a high risk patient. So the uncontrolled hypertension with significant renal artery stenosis. So the trial here also showed that there was significant BP reduction of almost around 20 millimeters. Mean BP was around 164 or something, and it came down to around 140. So there was a 20 millimeter difference in the intervention group in Hercules trial. So 2000 drastic, 2006 STAR trial, 2009 Astral trial, 2014 Coral trial, all these showed that there was no difference in the medical therapy versus interventional therapy. And the Hercules trial showed that there was a significant BP reduction when you did renal artery intervention in a high risk uncontrolled BP patient. Now we'll go on to the poll number 3. Can we have the poll number 3?
Netcast, please play the poll.
Hi, can we have the poll? Yeah. So 64-year-old male with a history of diffuse atherosclerosis presents with his third episode of sudden onset flash pulmonary edema in 5 months. Imaging reveals high-grade bilateral renal artery stenosis. His blood pressure is high despite adherence to 4 antihypertensive agents. How should this patient be managed according to our current expert consensus and trial sub-analysis? Can we close the poll and over to Dr. Iqbal?
Thank you. Can we have the results, please? We have the number B as the popular one, urgent renal artery revascularization with stenting. We have Dr. Binu Bendra there. Dr. Binu, are you there?
Yes.
Thank you, Dr. Binu.
Thank you, Geo. I think Geo has already answered this question clearly.
I'll just put one the other way around. Like Dr. Binu, in your long experience as a consultant, how many cases of revascularization you must have reached in your management of renal artery stenosis?
Most of these patients are referred by the cardiologist. They find out that they have these patients have a significant renal artery stenosis, and they ask us what to do. So it is very often the cardiologist who refer to us. And as you know, when it goes to the cardiologist, patient is often symptomatic. Either they have a recurrent cardiac failure or a worsening renal function, and we are forced to give them the option of going on to open the renal artery. So I have had instances where patients have recovered dramatically, where the flash pulmonedema or the Pickering syndrome, which Geo mentioned, has recovered completely. So there are, just like we have anecdotal reports, I think I have often met across a patient who has had sudden benefit, where the dramatic benefit with revascularization. So having said that, in this particular patient, I would look at three factors. One is worsening of renal function. Second is the occurrence of recurrent flash pulmonedema as Pickering syndrome, as Dr. Geo mentioned. And then, of course, if there is uncontrolled hypertension. In these three situations, I would advise the cardiologist to go ahead and do a revasculation. Of course, for the patient and their relatives, the benefit of revasculation I would convey as four things. One is the renal size and the intrarenal vasculature, that is the RI of the intrarenal vasculature, and presence of proteinuria. And if, as Geo mentioned, if BOLD is available, I would have opted for it. I have not done BOLD so far in any of our patients. So in this particular patient, I think he has got a persistent cardiac failure, which is not responding to most for antihypertensive. So definitely, I think we should consider revascularization of the renal arteries.
Thank you, Dr. Binu. Thank you for that comments. And over to Dr. Geo.
Yeah, so we had the KDIGO controversies conference in report that came in 2020, and they have put forward some definite indications for revascularization. And as we have already seen, cardiac destabilization syndrome or your Pickering syndrome or your recurrent flash pulmonedema definitely is one of the indication for revascularization. Then you have progressive CKD with high-grade stenosis, that is more than 75% in bilateral disease or a solitary functioning kidney. Revascularization is indicated. When you have an acute kidney injury because of an acute renal artery occlusion or high-grade renal artery stenosis, you can go ahead with revascularization. Then medication intolerance, ACE inhibitor and ARB, you are giving that, and the patient is having a creatinine rise in high-grade renal artery stenosis. That also becomes a definite indication as per the KDIGO. And in kidney transplant patients with renal artery stenosis, automatically most of us, if it is symptomatic, if the patient's hypertension is on the higher side, creatinine is worsening, we go ahead with the stenting. Possible indications as per the KDIGO include chronic heart failure and high-grade renal artery stenosis, coexistence of progressive CKD and uncontrolled hypertension, asymptomatic high-grade renal artery stenosis, either bilateral or solitary kidney with viable renal parenchyma to prevent atrophy on the long term. New, that is less than 3 months of even dialysis patients with non-functioning but possible viable kidney, that has been put under the possible indications. And in no indication for renal artery stenosis intervention when the patient has moderate to severe hypertension alone, and if it is an asymptomatic unilateral or bilateral renal artery stenosis of less than 75%. So before going with a procedure, you always have to look at the viability of or non-viability of the kidney because of the atherosclerotic renal vascular disease. And when you have a duration more than 6 months, we usually say that it's unlikely that the patient, the kidney is viable. So if it is less than 6 months, that is the better scenario. And if the proteinuria is more than 500 milligram, the chance of kidney injury that has already happened and the chance of recovery might be on the lower side. And then you should have a cortical thickness, and the CMD, if it is lost and the cortex is very thinned out, then the chances of recovery is very low. And your RI should be more, if it is more than 0.8, that shows that your parenchyma is damaged, and if the revascularization are unlikely to benefit your renal function. And if the renal length is less than 7 centimeters, also that also shows that the parenchyma has been damaged. It's unlikely that the kidney will benefit from a revascularization procedure. Now, when you think about the revascularization, the complications, cholesterol embolization is the most important thing. Then you can have your contrast-induced nephropathy, and then there can be procedural complications like dissection, rupture, puncture site hematoma. All these things can happen. And restenosis rates is also possible. 16 to 70% cases can have a restenosis after your intervention. So, as already mentioned, surgical way of managing renal artery stenosis is as good or even better than, the results are even better than sometimes endovascular revascularization, but there is a higher rate of perioperative mortality of even up to 3.1%. But there are certain situations where surgical revascularization is preferred over endovascular therapy when you have an unsuitable candidate for angioplasty or stenting due to complex anatomy of the vessel, concurrent abdominal aortic aneurysms which needs an open repair, then you can go ahead with the renal repair as well. And when you have recurrent stenosis after percutaneous interventions, all those situations, you have to go for a surgical revascularization than an endovascular treatment. Now, the prognosis, most of these patients, up to 35% of the patients progresses at 3 years. So if you have a 50% stenosis at now, after 3 years, definitely most of them patients will progress. So that you have to keep in your mind when you have a patient with renal artery stenosis. And cardiovascular events are the leading cause of death, exceeding the ECRD risk. That's the reason why we have to aggressively treat them just like a coronary artery disease patient or a severe patient, reducing the risk of atherosclerosis. Monitoring strategy, usually you have to do a Doppler scan 6 to 12 months to track the velocity and the kidney size. And you have to regularly monitor the creatinine and the potassium as well. And post-intervention, as already mentioned, there is a restenosis rate of almost 60 to 17%. So you have to, even if you have done angioplasty in a patient, you have to think about a restenosis if you have if the hypertension recurs or the control of hypertension worsens, you have to think about a restenosis. So as we have been seeing all throughout the evidence, in the 1990s, it was all about stenosis. You have a stenosis, go ahead and clear the stenosis. And in 2009 to 2014, you had the Astral and the Coral trials, which showed that the medical therapy is as good as your intervention. So we moved away from intervention over that period. Now in 2026, I think we have to think about the physiological impact of the renal artery stenosis, and we have to assess the hemodynamic impact on the kidneys because of the renal artery stenosis. We have to move from the idea of is it narrow to the question of is it hemodynamically significant. So that should be our the way of moving forward with management of renal artery stenosis. So if we have to concisely say the algorithm for management of renal artery stenosis, when you have a clinical suspicion, because of resistant hypertension, flash edema, azotemia, then you have to screen with a Doppler scan. When you have a Doppler scan and you know that there is some amount of renal artery stenosis, then you diagnose and quantify with the CTA or MRA. And then you have the etiology, fibromuscular dysplasia, or then if it is a fibromuscular dysplasia, you can go for angioplasty with a balloon. And when you have an atherosclerotic renal artery stenosis, you can go with your medical therapy first. And when the medical therapy is making the patient stable, you can continue with the medical therapy. But if the patient is unstable with recurrent flash pulmonary edema, rapid decline in blood pressures, uncontrolled blood pressures, then you have to think about your angiography and stenting. So that will be a concise algorithm for management of renal artery stenosis. So the clinical takeaways would be screen wisely. Only screen when you have a high pretest probability. Don't do for all the patients. You will have false positives. Then respect the evidence. Definitely medical therapy is the default for renal artery stenosis, atherosclerotic renal artery stenosis. And stenting is for rescue indications when you have severe case scenarios. And treat the cardiovascular risk as well, because you have a patient who is atherosclerotic, your cardiovascular risk is as high as or the risk is more than a routine patient with diabetes or hypertension. Thank you.
Thank you.